Hello everyone, I'm Dr. Saeed Forouzanian coming to you from my new medical YouTube channel. As you may know, I'm a doctor in a country that YouTube and many other social medias are restricted in it. So my videos cannot spread out as much as I want because of the limitations that the government is doing in social medias. So I hope that I can spread my videos in English all over the world, in other countries, in any other English speaker countries. So I'm not great in English, but I try to share my knowledge, to share my experience to medical students, nurses, and any other person who is working in healthcare system. So let's start with one of the cases that I had a few weeks ago. 23-year-old man comes to emergency department with severe abdominal pain, actually epigastric pain, and nausea and vomiting. He has severe epigastric tenderness or moderate severe epigastric tenderness, and he used NSAIDs, I mean non-steroid anti-inflammatory drugs that may harm stomach. They may cause peptic ulcer. They may cause perforated peptic ulcer. So, diclofenac, piroxicam, ketorolac, all are from NSAID category. So, they can cause PUD, peptic ulcer disease, or even in this case, they may cause perforated peptic ulcer disease. So this is one of the differentiated diagnoses. Let's talk about another one. He is a man, he is a person under 30, I mean he is 23-year-old that has been came with abdominal pain and nausea and vomiting. It is rational if you think about DKA, diabetic ketoacidosis. He had an stress, physical or mental, a few days ago, and he got worse and worse, and his chief complaints are nausea, vomiting, and abdominal pain. So the correct answer may be DKA. Okay, let's talk about another differentiated diagnosis. Another one is pancreatitis. Why? Because he has severe epigastric pain and nausea and vomiting. So this case can be, the diagnosis of this case can be, maybe actually, pancreatitis. We are working in emergency department, and this case is a person that couldn't solve his problem in clinic. So he has been came to emergency department. So we have to think about life-threatening or severe disease and diagnosis. So let's talk about another DDX. Electrolyte imbalance. For example, he is a person that used NSAID, piroxicam, ketorolac, diclofenac, and or many other drugs maybe, and he did not receive enough water, and he couldn't throw away waste products from the kidney by urine. Why? Because these drugs may affect the urinary output and cause AKI, I mean acute kidney injury or acute kidney disease. Do you think about any other differentiated diagnosis? If yes, please comment it for us. So, the most probable differentiated diagnosis, actually the most probable life-threatening and critical differentiated diagnoses that came to my mind are these four. And I'm going to rule out them by asking paraclinic, I mean lab data or imaging, laboratory studies or imaging or any other things. So I'm waiting for the result of laboratory and imaging. Let's talk about drug. Which drugs do you think are suitable? Is it important or necessary to prescribe IV fluid for this case? Yes. Why? Because if the diagnosis was pancreatitis, we need to do serum therapy. It is an essential key of treatment of pancreatitis. So IV fluid is important, ringer like that or normal saline. And if we are thinking about DKA, again, serum therapy is a key element for the treatment. And one other thing, do not forget to ask ECG from the patient, because you can find, for example, some electronic imbalance, I mean, ion disorders by ECG. So, we were talking about serum therapy. So, if you are thinking about pancreatitis, if you are thinking about DKA, you have to do massive IV fluid therapy. And if you think about electrolyte imbalance or any other problem in the stomach or GI system, again, serum therapy may be useful for the patient. And you have not any limitation for serum therapy for this patient. And one other thing that I forgot to talk about is polyuria and dysuria. This patient has not any of these symptoms. So, because of these 4 DDX, serum therapy is necessary for this patient. So, serum therapy or IV fluid, 1 liter stat, I mean at the first visit. And the other thing, we have to protect the GI system. If it is PUD or PPUD, pantoprazole or famotidine are good choice. If he has pancreatitis, or even for any patient comes to hospital because of stress ulcer, it is a good choice to start a PPI or famotidine for this case. So I start pantoprazole, 40 milligram IV stat, and it is important to suppress the nausea and vomiting of patient because they may bother the patient, and actually they may cause problem in esophagus of patient. So I prefer to use, for example, ondansetron or promethazine, or maybe metoclopramide or Plasil for this patient. Actually, promethazine is good because it is a good sedative drug. It is the first generation of antihistamines and is good for this patient. So I think still there are enough. We prescribe them for the patient till the results comes from laboratory and the imaging. CBC, the white BC was a little elevated. Urea was 180. Creatinine was 8. Sodium was 120. 6. Potassium was 7. It was 130. Amylase was 130, although it is more than upper limit normal. But in order to establish the diagnosis of pancreatitis, it is important to have amylase 3 times upper than upper limit normal, but it was not 3 times upper than. It was upper than upper limit normal, but it wasn't 3 times. It wasn't more than 3 times. These enzymes were mildly elevated. It was normal. Lipase was normal. VBG was not established DKA. It was mild alkalosis. UA ketone was positive, but sugar and protein was negative, and BS or blood sugar was normal. In chest X-ray, we didn't see any sign of perforated GI or perforated peptic ulcer disease, and in ultrasonography, we couldn't see any sign of pancreatitis. So, the patient has not pancreatitis, he has not DKA, he has not PPUD, he may has PUD, he still may has PUD, but PUD is not the thing that be matched with this kind of symptoms, but he has electrolyte imbalance. Let's think about this case again. He has contusion 3 days ago. After that, rhabdomyolysis happened, and because of using these drugs that are nephrotic, are harmful for the work of kidney, because of using these drugs that are nephrotoxic, and the patient did not receive enough fluid, and he had fighting and contusion, and rhabdomyolysis happened for him. He got AKI, acute kidney injury, and due to AKI, he had nausea and vomiting because of elevated creatinine level. And maybe because of using this NSAID, do not received any food or any things, his peptic gut ulcer, and he had a mild to moderate peptic ulcer, so he had pain in epigastric. So this is the answer: electronic imbalance, actually AKI, due to rhabdomyolysis and low intake of fluid and using nephrotoxic drugs, using actually excessive and a combination of nephrotoxic drugs. One other thing, imagine this patient has pain. What do you think? Which drug do you use for this patient? Is it a good choice to use ketorolac again? No. It is a good choice to use piroxicam again? No. Is it a good, is it suitable to use acetaminophen? Yes, it has not any special gastric side effect or any renal side effect, so you can use Apotel or acetaminophen, IV slowly. You can use it by serum, by IV fluid, Or another thing, you can use opioid if the patient has severe pain. For example, morphine, betadine, or even fentanyl if it is needed for this patient to suppress the pain. So don't forget to suppress nausea and vomiting for this case, to suppress pain for this case by Apotel, acetaminophen, or opioid drugs. Be careful not to use NSAID for this patient and not to overuse, especially a combination of overuse NSAID in patients, in any people, because they may harm your gastric system and your kidney function, may affect your kidney function and may cause AKI. It is very common, especially if you have a history or a risk factor for it. For example, in older people, you have to be careful about using these drugs. In people who have a history of gastric ulcer or gastric bleeding, GI bleeding, you have to be careful about using these drugs. NSAIDs, and especially in people who have a heart disease, for example, for who have hypertension or who have heart failure, that are in more risk for AKI, you have to be careful about using NSAIDs. Okay. What other thing we can do for this case? We have to be careful about potassium. It may be toxic for the heart. It may be toxic for heart. So it is important to recheck it. And in order to reverse the toxic effect of it on heart, we have to use calcium. We prescribe calcium, for example, calcium gluconate, IV, slowly, under cardiac monitoring, in at least 10 minutes, in order to reverse the toxic effect of potassium on heart. But be careful that this case may have pseudo hyperkalemia, and this high level of potassium may be false, so we have to recheck it without any tapping to the hand before getting the blood sample. So what should we do for this? Actually, fortunately, this case, I saw this case here, and I consult with internist and nephrologist as soon as possible, and thanks God, he cured actually, and we did not need dialysis or any invasive treatment. So this patient got monitored in nephrology yard by nephrologist and internist, and after a few days his creatinine level comes to, as I remember, to 1, and he cured. So thank you for paying attention to this case. I hope this case would be useful for you. I'm Dr. Saeed Forouzanian. I will be thankful and appreciate you if you share my video for your friends. I'm here with a limited internet access, with restricted YouTube, Instagram, WhatsApp, Telegram, or any other international social media access, and I hope can attract English speakers medical healthcare system. I will see you next week in another episode by another emergent case. See you soon.